Hello and welcome to the webinar by Radcliffe Cardiology. It's with great pleasure that we are going to talk about timing of heart transplantation and LVAD therapy, how we can balance the benefits and risks of heart transplant and LVAD therapy, and what are the latest surgical insights. My name is Dr. Owais Dar. I'm a heart transplant LVAD cardiologist at Harefield Hospital. And I'm a senior lecturer at King's College London. And we have a great speaker with us. It gives me pleasure to introduce you to Mr. Espeed Khoshbin, who is a cardiothoracic transplant surgeon at my institution at Royal Brompton Harefield. He's our most senior transplant surgeon. Espeed, hope you can say hello to everybody.
Thank you. Hello, everyone, and welcome.
So this is going to be an interactive session, which will feature about 15 minutes of live audience Q&A towards the end of the talks. Please feel free to put in any questions during the talk on the interactive web page, and we'll endeavor to try and answer these questions, as many as possible, by the end of the broadcast. And without further ado, I'd like to move on to the first presentation, which I'll be giving, essentially about transplantation and LVAD therapy. The talk is summarized into three different sections: advanced heart failure recognition and decision-making, cardiac transplantation, and then LVAD therapy. So if we go straight into it. So timing of transplantation and LVAD therapy and the consequences of getting it wrong. And if there's one slide I'd like you to take away, it would be this. So too soon, and the patient takes an unnecessary risk of an operation and is exposed to long-term complications of immunosuppression transplantation and the complications of LVAD therapy. On the other hand, too late, the risk of the operation increases because the patient is sicker and the outcomes are poorer. And in the extreme scenario, too late a referral, the patient becomes untransplantable or unvadable because of complications such as pulmonary hypertension and liver failure. So the other possibility is that the patients run out of time to wait for a heart transplant because they're falling too sick and die whilst waiting. So getting the timing right is really, really critical. The indications of transplantation, well, you need to have advanced heart failure refractory to conventional medical therapy. So for those with LV systolic dysfunction, they need to be treated with ACE inhibitors, beta blockers, Entresto, and the four pillars: ICD, CRT, have their coronaries revascularized, have their valves treated, and so on. But it's once they're refractory to these medical therapies and they have persistent symptoms, should they be referred. But having advanced heart failure, when you look at the ESC guidelines, American guidelines, and the UK listing criteria for transplant, there's a whole list of criteria which you can see on here. It can get quite intimidating to put this into your head. So what I'd like to do is to condense this into a more memorable way. And what I'd like you to take away from this is also that cardiogenic shock or advanced heart failure is a really broad phenotype. And I hope this slide sort of exemplifies and sort of makes the point clearly. All of these patients have a low cardiac index. So they are in a low cardiac output state, the cardiac index less than 2.2. And the cardiac index is basically your cardiac output indexed to your height and weight. And anything below 2.2 is the low cardiac output state. And as anybody with advanced heart failure, have high filling pressures, have wedge pressures of more than 15. But you can see, and I see these patients day in, day out in my clinics and on the wards, there's a broad phenotype. You have the patients who are in NYHA class 4, who have low cardiac output state, high lactate, oliguric, hospitalized, and you'll see them on your ICU on inotropes and so on. They're quite easy to recognize, and they're sort of sliding fast. And in a lot of trouble and likely not to survive a few days or weeks. And they're sort of intermax 1 or 2 patients. On the other spectrum, you have the patients who are looking very well. They're walking around, they're working, tolerating their heart failure medicines without a problem. But if you were to do a right heart catheter study, they would still have a low cardiac index and high filling pressures, indicating a low cardiac output state. And then you've got these patients in between who are in the orange zone, so to speak. And there are subtle signs that these patients are not doing too well. They're going from green to orange, and are going to end up being in that red state on ICU and at the verge of death. And these signs include high worsening kidney function, worsening liver function, pulmonary hypertension, VT, increasing burden of VT on their ECGs and telemetry, or being admitted to A&E and so on, hospital admissions, worsening breathlessness, a rising BMP, cardiac cachexia, and inability to tolerate disease-modifying drugs. And looking out for these signs in your clinic visits or when you're taking your history will kind of highlight. So one of these features is sufficient to be considered to have advanced heart failure. So there is a mnemonic. The mnemonic is C, I need help, and it's published by Bonewall. In fact, the Bonewall publication just has I need help here, and I'm going to go through it to emphasize the hazard ratios or the risk of death associated with each of these features. But I've adapted this bit to call it C, I need help. So the first one, inotropes. Obviously, if you're on an inotrope, then your risk of death is 4 to 5-fold compared to those who are not on inotropes. But other things that we talked about in the previous slides are NYHA class 3-4 patients or NT-proBNPs above 1,000 or rising. It almost gives you a 3-fold increased risk of death. And organ dysfunction, as I said, worsening kidney function, worsening liver function. So if your creatinine or EGFR is just slightly worse than before, has an almost 2-fold increased risk of death. Ejection fraction of less than 20%. So the AHA guidelines and the ESC guidelines actually say ejection fraction of less than 30% in your clinics and in your practice. If you see somebody on maximal medical therapy with a low EF that's persistent, you need to consider referring these patients as they have almost a 3-fold increased risk of death. And this, when I first learned about this, was quite surprising to me as well. It's somebody who gets an appropriate defibrillator shock has a 6-fold increased risk of death. So if you have your DCM patient in your clinic, gets an appropriate shock, that is a harbinger of doom. Those patients don't simply need antiarrhythmic medicines or an EP referral. They should be discussed with a transplant center as a possible person who may be decompensating or at risk. Hospitalization speaks for itself. Patients who are hospitalized, certainly from the NICOR data and the UK heart failure database, patients hospitalized with heart failure following discharge have a 1 in 3 chance over a year of being readmitted or dying. And so these are patients that need very close monitoring. As I say, 1 in 3 of them will end up in trouble. And if they're already on maximal therapy, then perhaps before their discharge, they should be discussed with a transplant center. If you're finding your patient needs escalating doses of diuretics, or if they're not tolerating heart failure medicines and their blood pressure is low, systolics below 90 millimeters of mercury, again, you should be considering referral. And finally, I have a current PhD fellow who's doing research on this, and this is unpublished data, but certainly true. We're now, if a patient self-reports a more than 3% unintentional weight loss, i.e. cardiac cachexia, and this is not fluid weight loss, this is sort of muscle mass or fat mass, the hazard ratio for that, we will be publishing this shortly, is 4-fold increased risk of death. It's a really a good marker of poor prognosis. So such patients, you should be having a discussion with your transplant center. They're likely to have low cardiac output state and need a right heart catheter and further assessment. But many patients are inappropriate for heart transplantation and LVAD therapy. And who are these patients? So anybody for transplantation who gets to the point of pulmonary hypertension, where pulmonary artery systolic pressures are above 60 millimeters of mercury, or the pulmonary vascular resistance is more than 3 Woods units, or transpulmonary gradient is more than 15 millimeters of mercury, then that's a contraindication to transplantation. It isn't, however, a contraindication to LVAD therapy, and so they can be taken for LVAD therapy and then bridged to transplantation at a later date. High BMI, more than 35. One, it's unlikely we'd be unlikely to find a donor for such a patient for a heart transplant. But 2, the risks are slightly higher. And with advancing age, the likely benefit from transplantation reduces. So because of donor shortage and availability, the risks of surviving a transplant and obtaining any benefit are reduced. So I would say the general cutoff is 70. And when you start to get above the age of 65, you really need to have a robust recipient to go through the rigors of transplantation. And one of the common referrals we get for transplant assessment, but we end up turning down, are patients who are diabetic. So we can transplant these patients. However, following transplant, they get steroids and other drugs like tacrolimus that make diabetes worse and can lead to all sorts of complications and worsening of diabetes and end organ dysfunction. So if you already start off with quite significant end organ dysfunction, such as a HbA1c that's more than 7.5%, despite optimal treatment, or they've got proliferative retinopathy or neuropathy or nephropathy, then that's an absolute contraindication. Other things are quite self-explanatory: active infection, very poor kidney function that isn't cardiorenal, but it's more to do with intrinsic kidney disease, malignancy. Upon reinfarction, we would have to wait a 6-week period before we could take somebody on for transplantation because of the risk of bleeding whilst on bypass. And if somebody's got very severe peripheral vascular disease pre-transplant, they're going to have very severe peripheral vascular disease post-transplant and will still be limited. So they may not be the right candidate. One, because the risks are too high, and two, they won't accrue the benefit of transplant after transplant. CVA, that's quite significant, again, would be an issue. Substance abuse, tobacco, alcohol, and drugs. So the psychosocial circumstances need to be such that patients can go through the vigors of transplant and the follow-up afterwards, as well as be able to look after their heart and their bodies in a way that would be conducive to long-term survival. They need to be able to take their medicines properly and not abscond from treatment or not be compliant as well. Social support is crucial. They need to have adequate social support at home. For example, if you're homeless or have other difficult circumstances, then at risk of infection, and you need to be able to have good social support for outcomes to be very good. Some of these contraindications, however, are not contraindications to LVAD therapy. So you can be diabetic and go down the LVAD therapy route, and you can have other conditions like malignancies and thorns and be bridged to LVAD therapy. But I'll come on to that in the next few slides. One of the important concepts about transplantation is that the idea of waiting for a heart transplant and the probability of getting a transplant really determines whether you go down the LVAD route or whether you go down the transplant route, and you wait on a waiting list. So one of the things we do match for is blood group and size, but we also match for HLA antibodies. And this idea which I want to get across to you is that some of us carry antibodies against the HLA antigen of other people. So if you're a recipient and you carry antibodies in your blood against 90% of the population, your chances of getting a transplant are far, far reduced. On the other hand, if you carry no antibodies against the population, then you can pretty much take every donor available to you. So to give you an example of this, if you have somebody who's blood group O, BMI greater than 30, has antibodies against other people, and has had a stenotomy in our unit, a person like this would have a 5% chance of getting a heart transplant on a high priority list. So somebody like this, if we think they're going to be waiting 6 months, a year or so, are we going to be able to keep them stable enough for that long to be able to get a transplant? And that will inform going down the transplant route or going down the LVAD route. And so this kind of patient would more likely go down the LVAD route. On the other hand, we have somebody here who is blood group A, B, or AB with a BMI less than 30, doesn't have antibody against other HLA antigen, and has had no previous surgery. And this person in our institution has an 88% chance of getting a heart transplant over a 3-month period on a priority list. So if we're able to keep them stable for that long length of time, are likely to list them for transplant. finally, then one of the things you need to understand about waiting lists is that the waiting lists in the UK worldwide are getting bigger and bigger and bigger, and there's more and more people waiting. Many people die on the waiting list, so we need to consider that in our decision making as well. And nowadays, as a result of that, at least half the patients are bridged to transplantation with left ventricular assist device or mechanical support therapies. So some of the patients who are not eligible for transplantation, we talked about them, diabetics and pulmonary hypertensive patients, are eligible for LVAD therapy. But there are others as well. So, for example, age is less of a barrier to LVAD therapy, but you still do need a robust patient who isn't frail and who hasn't got too many comorbidities. HIV is possible in transplant if it's controlled. Hep B, Hep C, but more particular, can be more of an LVAD candidate. I would mention diabetes, those on dialysis as well. Depression or malignancy with an expected survival more than a year, you can bridge them to candidacy using LVAD therapy. And this is from the European Association of Cardiothoracic Surgeon consensus guidelines on mechanical support. So absolute contraindications to LVAD therapy are active systemic bacterial or fungal infections, severe aortic regurgitation or with a mechanical aortic valve, severe mitral stenosis, irreversible liver failure, because we will not be able to, patients will die on post-surgery with liver problems, and there's no machine like dialysis that will be able to recover the liver, and dementia and cognitive impairment and active substance abuse and the patient not willing to change. And these are all absolute contraindications to LVAD therapy. So in terms of the decision-making tree, what I would suggest, does your patient, first of all, have advanced heart failure? Do they meet one of the I need help criteria? If they don't, then carry on with medical therapy. If they do, are they eligible for transplant? And if they are eligible for transplant, then they should be considered for transplant listing and placed on the waiting list. And if they are placed on the waiting list, is there enough sufficient time to wait for a donor heart to become available before any deterioration? If they look like they're deteriorating, then you should be considering them for LVAD therapy as a bridge to candidacy or destination therapy. But if they're stable on the waiting list, they remain on the waiting list until they get a transplant. On the other hand, if they're not eligible for transplant because they have pulmonary hypertension or they're diabetic or they have other things like cancers which are partly cured but are not completely in remission, then you might consider them for LVAD therapy for bridge to candidacy. Or if they're above the age of 65, you might consider them for destination therapy, i.e. they're going to live out their life with their LVAD. So that's sort of giving you a gist of an idea about the pre-referral stage and who to refer and when, the kind of things that we're going to be looking at in terms of indications and contraindications and some of the decision-making and then the nuances of it. But talking about transplantation and what it can offer now, transplant's been around for 50, 60 years, and Christian Bernhard, depicted here on this slide on the bottom right, was the first person to carry out a successful human-to-human heart transplant. Most of the work had done by Shumway and colleagues in Stanford, and Christian Bernhard actually learned his trade in the US, but the laws at the time in the US didn't recognize the concept of brainstem death. So Christian Bernhard was lucky enough to be able to go back to his native country in South Africa, Cape Town, and in the Groote Schuur Hospital at the top right-hand picture here, he was able to carry out the first human-to-human heart transplant. And Louis Wishank was the first recipient. He was a 53-year-old gentleman, diabetic, but with an ischemic cardiomyopathy and on maximal therapy, and didn't really look like he had long to live with heart failure. And Denise Daval was a 25-year-old young donor who had a road traffic accident in Cape Town and was whisked into hospital by an ambulance and was declared actually circulatory death at the time. Christian Bernhard approached her father and it looked like it was terminal, she wasn't going to survive, and the father agreed to donate her heart. So Christian Bernhard and his brother were in adjacent theaters, and they took out Denise Daval's heart and implanted it into Louis Wishank's. 18 days later, sadly, he died of a pneumonia. They thought that he had severe rejection. They were really paranoid about that, and so pulsed him with more and more steroids and other immunosuppressants. But later, when he died and did an autopsy, they actually realized that they had pneumonia. So it sort of highlighted some major issues with transplantation early on. And quite a lot of centers worldwide started to transplant. In fact, they did quite a few in the first year after Christian Bernard had done it. But these numbers dropped because the outcomes were so poor. And only 5 centers in the world, Stanford being one of them, the Goethe Skier and the Le Petit in Paris, carried on with transplantation. And this early work done in the first 10 years post-transplantation really gave us an idea of who to transplant with recipient criteria and so on. But there were 3 big breakthroughs that essentially established transplantation in the therapy that it is. And the first one was donor preservation. Christian Bernard had to do the heart transplant with the donor and the recipient in adjacent theaters, which would be a big issue sort of logistically. But then Norman Shumway and colleagues, they did lots of sort of animal experiments which showed that you could take a donor heart, preserve it on ice, cool it down to below 5 degrees, and that heart would still be viable. You could try, if you were to transplant it into a recipient, you still had about 4 to 5 hours of time so that the heart could be reanimated and would do well. And nowadays we use a machine called the organ care system, which allows the heart to be taken out, and you can actually see the heart pumping, and the surgeons and the retrieving surgeons and the transplanting surgeon can assess the heart in real time. It often also gives our surgeons more time to do the operation. And this is called warm preservation because the heart isn't cooled down. So that was one major breakthrough. The next breakthrough was the development of better immunosuppression. And Jean Borel accidentally found a novel new drug in the derived from soil fungus in the 1970s. He called these drugs calcineurin inhibitors, and cyclosporin was the first one that was discovered. And what we realized was that this was a drug that could block T cell function, and it was a real breakthrough, because when they use it in kidney transplantation, suddenly kidney transplant patients survive for much longer periods. And it was tried in heart transplantation. And you can see in the bottom right-hand corner, initially steroids and azathioprine were the gold standard drugs, but as we added cyclosporin and then cyclosporin with azathioprine, the 5-year survival suddenly really became meaningful. The 5-year survivals are around 70% instead of, below 50%. So that was the next big breakthrough. And the third one was to do with the development of a technique of minimally invasively biopsying the heart. A team in Japan in the 1960s had described a technique using a bioptome rather like this picture here, where you could take snippets of the septum of the heart and access the right side of the heart and the septum via the subclavian or jugular veins. Philip Caves, who's a cardiologist in Stanford, modified the bioptome and then tested it out on 20 to 30 dogs who'd had a heart transplant, and was able to biopsy all of their hearts within 15 minutes with no complications, and see inflammatory cells within the heart, i.e. depicting rejection. So a whole new field, a whole new department of transplant histopathology was created as a result of that. So suddenly now you could recruit, get a donor from at a distance. You could preserve the heart and had more than roughly 4 hours to transplant the heart. You had better immune suppression, and you could diagnose rejection in a better way, in a more reliable way. And this really allowed transplantation to be established as a therapy. And also, in addition, as I alluded to before, the early experience of the first 200 heart transplant taught us a lot of things. One of the things was that heart transplantation is not a panacea for all patients with advanced heart failure. It should be the reserve for patients with significant chance of post-op rehab and survival. And as a result, all these recipient selection criteria, which I alluded to at the beginning of the talk, came about. what they also realized was in the post-transplant care, early mortality is largely down to rejection and infection, and late mortality is largely down to renal failure, transplant-related coronary artery disease, and malignancy like lymphomas and cancers and so on. So as a result, post-transplant cardiologists, that whole specialty became born, and we have all sorts of criteria and guidelines on how to manage transplant patients and minimize these complications now. So currently, around 5,000 to 6,000 heart transplants are done in North America and Europe. So it is really a therapy for the few, largely because of donor availability. And current median survival is around 12 to 13 years, and conditional survival, so if you survive the first year of heart transplant, it is more around 15, 16 years, and in some centers it's up to 20 years. So you can get really, really good long survival, and you've got to remember these patients probably are not going to survive a year or two. Most of these patients live near normal lives. They take a few immunosuppressant medicines, but often many of them go back to work. And if they don't go back to work, it's because they choose not to. They're sort of NYHA class 1, able to run marathons or long distances and so on. But there are complications. I listed some of them here. Diabetes, at least a third of these patients are diabetic by 5 years, and quite a significant amount, a quarter of them will have quite significant kidney disease by the end of 10 years. And coronary artery disease becomes a problem, so at least half of these patients will have significant coronary disease by 10 years. So moving on to LVAD therapy now, this is now become the treatment of choice for 50% of the advanced heart failure patients we see. And a lot of patients, as I said before, are bridged with to transplantation with LVAD. And this is what the very first LVAD looked like. And you see a patient here on a treadmill being rehabbed on this sort of device here, which almost looks like a washing machine. And the idea behind it is that you have a cannula which is implanted into the left ventricle. It sucks blood out of the left ventricle and pumps 5-6 liters of that blood into the aorta. And the very first heart device called the HeartMate 1 device in the 1980s was developed. It had a polyurethane diaphragm, which was pushed backwards and forwards. It created a vacuum effect and a suction effect, which sucked the blood out of the cannula from the left ventricle, and it had valves inside it, which meant that the blood could only move from the left ventricle into the aorta. So essentially it was quite big, it was cumbersome, it was heavy, it had multiple moving parts, and it was prone to mechanical failure and thrombosis and other sorts of bleeding complications. But in principle, you were able to take a patient in quite extremis and get them to rehab, which is what you're seeing on this picture at the bottom right. And this gentleman, Professor Fraser, who's still working at the Texas Heart Institute, published the very first case of a patient going home with one of these devices. And this device, you have to have a little cable with a wire coming out of the belly, which is connected to a battery, which powers the actual LVAD device. He ran the very first bridge to transplant trial. It was 17 centers across the USA, non-randomized, and 108 patients were all approved for transplant, were given the option of carrying on the transplant waiting list or having that LVAD that I just showed you, the first HeartMate 1 device. And this will illustrate a really key important point, which still holds true today. So these patients were really sick. About a third of them decided to stay on the transplant list, and the remaining 2/3 elected to have the VAD. They were quite poorly, had very low cardiac indexes. They were low cardiac output states, low blood pressure, high filling pressures. And to give you an idea, half the patients had creatinines above 194. They were quite a significant end organ dysfunction. They were really sick individuals. These were the exclusion criteria, quite significant lung problems, high pulmonary pressures, very old age, stroke, infection, the sort of exclusion criteria. And this is the kicker, so to speak, in that those people who underwent transplantation, so if you stayed on the transplant waiting list, only 36% ended up having a transplant. But if you went up and had the LVAD, 71% ended up with a transplant. And the 60-day survival was better with the LVAD. And the 1-year survival in those who underwent transplantation was better if you were bridged with the LVAD. And the 1-year survival for those with renal dysfunction, again, was better for those with the LVAD. And what this is telling us is that you can be too sick to have a transplant. Your outcomes can be really poor if you take really frail patients with multiple organ failure, cachectic, frail. And with the LVAD, what you can do is you can rehab the patient on the treadmill. You can normalize their liver and kidney function to a point where transplant's more likely to be successful. And you don't have to keep your patient waiting on inotropes, and while on inotropes, they're deteriorating and declining. So nowadays, short-term mechanical support, ECMO, LVAD, Levotronics LVADs, and impellers are used specifically to get people from a very sick state to a more transplantable state, or to a state where they can even have a durable LVAD with less risk. So I want you to take away that as a key take-home message for short-term mechanical support. Now, durable support, the key study now is the seminal trial, the Momentum 3 trial led by Mandeep Mehra, who you can see on the type, was a recent randomized controlled trial, 1,028 patients, published in 2019 in the New England Journal. And they took patients with advanced heart failure refractory to medical therapy, and there were patients who had the LVAD as either bridge to transplant or destination therapy. It was 69 centers in the US. 516 of them were randomized to the HeartMate 3 device, which is this device you can see at the bottom, versus the HeartMate 2, which was the previous sort of gold standard device. And I'll just take you through the study. It's a really neat study. Inclusion criteria are pretty much what I've talked. They need to have advanced heart failure, NYHA class 3 or 4 symptoms. They were all adults, either inotrope dependent or had a very low cardiac index and degree of end organ dysfunction with low ejection fractions. Exclusion criteria, as mentioned before, many of the contraindications discussed, cirrhosis, moderate aortic regurgitation, stroke, peripheral vascular disease, restrictive cardiomyopathies, and active infection, and so on. And the endpoints were the composite endpoint of survival at 2 years, free from stroke or reoperation or malfunction of the pump. Secondary endpoints, things like pump replacement at 2 years, and other endpoints include actual survival, rehospitalization, functional class and quality of life, and finally, adverse events, stroke, bleeding, right heart failure, and infection. So I'm going to give you the results of these, and you can see what a game changer these devices are for such patients. So the HeartMate 3 device, in terms of the primary endpoint, survival at 2 years, free from disabling stroke or reoperation or replacement or malfunctioning device, was much, much better, 76.9%, significantly better HeartMate 3 compared to the previous gold standard, the HeartMate 2. And the principal secondary endpoint as a pump replacement in terms of mechanical failure and thrombosis and so on was only the minority of 2.3% of patients at 2 years versus 11.3% with the HeartMate 2. And again, more impressive is that the actual overall survival was around 80% at 2 years versus 76%, 77% with the HeartMate 3. And it was quite a significant improvement. But when you look at 5-year survival, for the very first time in history, durable LVAD therapy now has a median survival more than 5 years. And if you just take a subselection of those patients who were simply for DT therapy, the 5-year survival was 52% compared to 36%. So if you take now a patient who has advanced heart failure, have them on medical therapy, so they're inotrope dependent and so on, they have on medical therapy based on the REMATCH trial, a likely 8% 2-year survival. But even now with these current devices, with the HeartMate 3, there's up to an 80% 2-year survival and a median survival of 6-7 years, 5-6-7 years with the HeartMate 3. And in terms of quality of life, their quality of life is massively improved. They go from being NYHA 4, NYHA 3 to having NYHA 1, 2 symptoms within the first few months. And that's lasting up until 2 years or even more. And their 6-minute walk distances and so on are significantly improved. If you look out to 5 years, then you can see that most of these patients will remain NYHA class 1 or 2 and will have 6-minute walk distance where they can manage up to a quarter or a third of a kilometer within 6 minutes. So they do improve in their functional class and survival. But these devices still have their issues, although much better with the latest HeartMate 3 device. It needs less anticoagulation. It needs you don't have to have your patients on aspirin anymore. They can be managed with lower INR rates afterwards. But there's still issues related with infection. Approximately 1 in 5, 1 in 4 patients will have an infection by 5 years, mainly from the driveline, which is cable that comes out of the belly. They're at risk of bleeding, either GI or intracranial, and their risk of thrombosis as well, although that's becoming less of an issue with the HeartMate 3 device. So GI bleeding rates at 5 years, up to a third of patients, infection up to a quarter of patients, and right heart failure, so there's left ventricular assist device support, but about a third of patients will need some form of diuretic as well, just to manage the right side. So I'm going to end my presentation. So to summarize, we talked a bit about advanced heart failure recognition and decision-making. We've talked a bit about transplantation indications, contraindications, timing, and adverse effects and survival, and likewise with LVAD therapy. So now I am going to hand over to Mr. Espeed Khoshbin, who we're really keen at Espeed. Look forward to hearing from you.
Thank you very much, Dr. Dar, for your kind introduction at the beginning, and also for going through some of the recent trials and the literature on heart transplantation and left ventricular assist device surgery. It is quite an honor, and I'm very thankful to Radcliffe Cardiology for giving me this opportunity to summarize some of the surgical aspects of heart transplantation and left ventricular assist devices, such as LVAD. Right, I'm from a place called Harefield Hospital in London. We are one of the major transplant centers in the UK, and are the transplant center for London. We perform one of the highest numbers of transplants and left ventricular assist devices in the UK. Historically speaking, we've performed a number of different types of transplant. In fact, the first heart-lung transplant was performed 41 years ago by Professor Sir Mahdi Yaqub, and since then we've performed a few of those transplants. That was the first in Europe, and we've been really pioneering in the field of transplantation and dominoes, and we've done quite a few heterotopic heart transplants. But the real treatment of end-stage heart failure, surgical treatment of end-stage heart failure at the moment is orthotopic heart transplantation, which is transplantation and replacement of the heart in its normal anatomical position. And heart transplantation, orthotopic heart transplantation, is now the gold standard treatment for end-stage heart failure. If you don't remember anything from today, I'd like you to remember this slide. This is a phenomenon that I call lining up the moons. If you have good donor and you optimize and have a good recipient and perform a good surgery, then your outcome of transplantation is going to be good. Okay, this is a surgical lecture, and I'm going to be taking you through some of the surgical procedures, and there are some graphic photographs here of transplantation. first stage of transplantation is opening the chest and called median sternotomy. Then when we have cracked the chest open, the patient is put on cardiopulmonary bypass through a bicable technique. Pipe is placed in the superior vena cava, one in the inferior vena cava, which drains the blood from the heart and returns it into the ascending aorta. Patient is heparinized for that, and at that stage, you can see I am getting ready to put the cross clamp on, which would be the beginning of the stage of no return. At this stage, the SVC and IVC has been snared and separated from the heart. And as the cross clamp goes on to the ascending aorta, then we are able to remove and explant the heart from the chest, leaving the chest empty. This starts from a dissection into the right atrium and then is extended down towards the coronary sinus, then the left atrium, aorta, pulmonary artery, SVC and IVC, and the heart is then delivered outside the body, leaving a good cuff of left atrium, aorta, pulmonary artery, and both KV for anastomosis to the donor heart. The heart, when it comes out of the body, continues to beat for a period of time, and that always impress the visitors to see the heart beating outside the body. It's been explanted. Then is a process of preparing the donor heart. You can see here I'm trimming part of the left atrium. We will inspect the heart and make sure that all the different chambers and all the anastomotic sites have been trimmed and ready for anastomosis. The heart is then put into the empty cavity, and we sew the heart onto the patient's body with Proline sutures, starting down from the left atrium up to SVC, up to IVC, then pulmonary artery, and then aorta, and finally the SVC. And this is the preferred method that I use for my heart transplantation. Before releasing the cross clamp, we make sure that we have given the steroids, and then the heart is left on cardiopulmonary bypass for a short period of roughly about 30 minutes for reperfusion before we start to wean off and decannulate. And that is the heart ready to be readily beating. And you can see here from the pressure measurements and the theory that the heart is functioning well and the chest is closed. And Owais has already shown this. The result of the heart transplant is improving and currently lies at about 12% median survival for a heart transplant. So you may ask, why do we need to have LVAD? So we discussed this already, that LVAD can be used as a bridge to transplantation as donor organs are in short supply. Some patients have got quick progression of the disease and they will not make it on the transplant list. They may have an LVAD as a bridge to transplantation. And then still, despite that, patients do die on the waiting list. There's also a bridge to candidacy, and we've already touched on that. And there is a graph showing that patients with raised pulmonary pressure will have poorer outcome than the others. And that was, as Dr. Dar mentioned, about 3 Woods unit will have significant reduction in survival of these patients. And then there is a fact that it is quite convenient to be able to take a device off the shelf and be able to do an operation such as LVAD, saving the patient's life immediately and without having to wait for a donor organ. So that is an advantage of having the possibility of doing a left ventricular assist device. And you can see again, some of these slides are the duplicates from Dr. Dar, and you can see the Momentum 3 trial and the results that show it in a magnetically levitated device. Then the current median survival is over 5 years, which is pretty reasonable, in my opinion. So what about implantation of left ventricular assist devices? Well, that's not that much more complex than putting a heart transplantation. Again, I'm going to show you some graphic pictures. My preferred choice of exposure for an LVAD is through median sternotomy. This is also can be done through bilateral thoracotomies with some advantages and some disadvantages. But this appears to be my approach of choice. The device itself, as you can see here on the right-hand side, is being prepared and connected to the outflow graft by our specialist nurse and tested with the console to make sure that it's all working before being passed to me for implantation. And before I actually start making holes in the heart, I will assess the what we call the sweet spot on the apex of the heart where this LVAD is going to be placed. And you can see on the right-hand side picture where my finger is pressing on the apex at the sweet spot or the soft spot of the left ventricle and showing me where I should be placing this device with the help from transesophageal echo in this case. Then you can see me storing this ring. This is the ring from the HeartMate 3. And we sew that onto the apex of the heart where we put a mark for the sweet spot. And I use a sharp coring device as shown over here to make a cylindrical shaped piece of apex out, leaving a hole for me to place the LVAD into. And you can see here I'm checking inside the apex to make sure there's no clots or any debris left that would cause problems with the device or cause stroke for the patient. Then the device, which in this case again is a HeartMate 3 device, is going to be pushed into the ring and then locked in position. Next stage is passing of the drive line. Is the white structure you can see on the top. I am making a tunnel with this very long metal structure, and then that is tunneled and connected to the console. Then it's time for the outflow tract to be sized and de-aired with a heart full, and then it is anastomosed with the side biting clamp onto the ascending aorta with sutures. That is usually placed at about 45 degrees angle to the aorta. And this is what you will see at the end of this operation. And that's the TOE image showing the flow of the Doppler flow of blood through the pump head, which you can see here. This is the X-ray of the same, and that shows the arrangement of the pump head and then outflow tract and you have got the drive line going there. Okay, if I have to compare a transplant to the LVAD surgically, what would I say? Well, heart transplantation, orthotopic heart transplantation, has a superior median survival. There's no doubts about that. 12 years versus over 5 years for LVAD. And it remains the gold standard treatment for end-stage heart failure. However, LVAD surgery is an emerging technology that there is still so much we don't know, and there's so much we don't know about the longer-term outcome of LVADs and how this will improve in the future. There are research concentrating on using totally implantable devices that don't require the drive line, Achilles heel of LVAD therapy, which causes infection. So there are number of research studies that are looking at transcutaneous transfer of energy, having total implantable devices, both LVAD and total artificial heart. So it's something to look forward to in the future. However, LVAD has shown a significant proven safety and efficiency. So there's no doubts that it's a good, viable option, and we use it in a day-to-day basis. However, compared to the orthotopic heart transplantation, it has slightly narrower indications. Heart transplantation treats both right and left ventricular failure, whereas LVAD concentrates on treating the patients with near normal or normal RV function. So it is a narrower indication. There is, from time to time, you see people using durable devices on the right-hand side, but this is not standard of practice at the moment. However, LVADs are simpler procedure, and they have, as a result of that, they have more worldwide applications, as opposed to transplantation, which is a more complex process, requires a nationwide organization of donors and recipients and so on and so forth between different groups and different hospitals. And that is why in many developing countries, we have been unable to establish a successful transplant center. However, with LVAD therapy, there's a possibility that these countries would be able to treat some of their heart failure patients with LVAD therapy, because really what they need is a reliable source of energy or electricity, and also someone to be able to troubleshoot and look after these patients. However, what is definitely for sure is that both heart transplantation and left ventricular assist devices increase survival and quality of life in patients, and that there's no doubts about that. In fact, transplant and LVAD are used together. Of course, there are destination therapy, but in a lot of cases, there are bridge to transplantation or bridge to candidacy, as we mentioned. And more frequently these days, there are one-stage approach to durable LVAD implantation in patients with low intermax classifications. That is, patients with intermax classification 1 and 2, crash and burn, or patients who have got problems with organ dysfunction. And that is still slightly controversial, but the argument is that these patients will have a reduced risk of having repeated high-risk surgery, which also exposes them for more transfusion and more development of HLAs and also there is cost implications with that. And the disadvantages are such as not being able to assess these patients thoroughly as we do before transplantation. So there's pros and cons, but there is a movement towards one-stage durable LVAD implantation for low intermax class patients. And it doesn't really need a mathematician to tell you that if you are supporting someone with a left ventricular assist device, and then after a few years you give them a transplant, there's likelihood that you may actually improve their longevity. And as we use more and more as we use more and more left ventricular assist devices, the cost of these devices will reduce, and there is a reducing cost per quality of life years in these group of patients, reducing the gap between that and heart transplantation. However, the heart transplantation is becoming a more complex procedure in the most recent years for transplant surgeons, and that's for a number of reasons. One of them is that we are getting more and more patients with congenital anomalies needing transplantation. They could be as simple as something like Epstein anomaly, where you've got all the tubes in the right place and you just have to do the transplant, or more complex situations where you've got patients such as single ventricular physiology being supported with a left ventricular assist device as a bridge to transplantation to support their right systemic ventricle. There are other conditions such as failed treatments for Fontan procedure. So failed Fontan is another one that we are seeing more as children are growing and reaching their adolescence and adulthood. They're becoming more and more prone to developing heart failure and need transplantation and complex transplant. And also there are some syndromic patients which have both create issues with surgical but also medical problems, such as patients with mitochondrial disease, which may have multi-organ dysfunction, or they have multiple syndromes that require expertise from neuromuscular or from other types of medical professionals. There's also problems of syndromic patients with cognitive impairment, and then the dilemmas and the controversies that surrounds transplantation in patients with cognitive impairment that exist. But more surgically speaking, the complexity that comes with increasing the number of LVAD patients on transplant list is the process of re-entry and the possibility of injury to either the driveline, the outflow graft, or even to the heart itself. And that may be to some extent reduced by using bilateral thoracotomy approach. But in our experience, the bilateral thoracotomy approach is not exactly as advertised, and it is sometimes even more difficult than performing this sternotomy in these, or re-sternotomy in these patients. And occasionally you get this sort of CT scan where you've got the outflow tract right underneath the sternum. As you can see here, it's a nightmare case for opening the chest. So as a result of these, I published recommendations in the Art of operative techniques onto transplant ventricular assist device explantation. Try to give some sort of guidance as to how we would minimize the risk of injury to these organs and devices into the chest. And basically, the process of safe entry into the chest with the patients who have got LVAD in situ begins at the time of transplantation. And there are things that you could do to minimize the risks. I hope you can appreciate from this picture that there are things that I have done during the surgery to minimize the injury to the outflow tract and the drive line during the re-entry. You may be able to recognize this structure on the right-hand side. It's a right structure. Unfortunately, I'm unable to show you with an arrow, but there is a white structure just on the side, on the right-hand side, and that is the drive line. This drive line position is completely away from the middle of the wound, where when you go to do a resternotomy, you can actually injure it. But that has been put well away from injury at the time of re-entry. There's also, you may be able to appreciate that I have left a shelf of pericardium on top of this outflow tract. And that shelf, together with its attachment to a Gore-Tex membrane, would protect this outflow tract from being injured during re-entry. You can see the Gore-Tex membrane, which is being attached. This is a overlapping Gore-Tex membrane technique with the one inferior one attached to that shelf for pericardium and the superior one is attached to the pericardium on either side, and with the drain going between the two. And that is a good way of trying to prevent injury to the heart or any of these organs on re-entry. Another point that I want to mention is when you go for a VAD explant, you should always allow a good amount of time so that you're not rushing to get in and try to explant the heart. I usually leave at least 2.5 hours from the point of when the patient arrives at the anesthetic room to the estimated arrival of the organ, so that there's good time for us to be able to separate all the structures with a good hemostasis before doing the final irreversible part of the explantation, which is clamping the aorta and removing the aorta, then removing the heart from the chest. The 2.5 hours is what I would recommend in this situation. You also want to have good members of the team present. So you need to have good, competent assistants there to help you in doing this procedure. You also need to have a good presence of your VAD team in the theater, amongst others, to help switch off the VAD and troubleshoot when the VAD starts to cause a lot of havoc by alarms going off left and right and center for different reasons, and reassure the surgeon that everything is okay, so that I can get on and perform the correct operation safely. Another technique that I use often when I do VAD explantation in a redo situation is putting 2 strong ethibond sutures on either side of the sternotomy wound. This will allow me to pull up on the sternum while opening the chest with the oscillating saw, and hopefully reducing the chances of this actually injuring the heart drive line or the outflow graft. That could also, this sort of suture placement can also be helpful in cases of complicated sternal reentry. For example, if you happen to hit the drive line or hit the outflow tract when you're re-entering the chest. And one of the other things that has helped me particularly when this sort of complications happen is having the organ care system that allows slightly more prolonged period of myocardial preservation of the heart while we deal with the complication of re-entry by establishing bypass and so on. When you're in and you've taken the heart out, it is important to be very careful about the position of the phrenic nerve. You can see here, I hope that there is a line. This is where the phrenic nerve passes in the back of the pericardium, and that is very vulnerable because the head of the LVAD pump is actually in close proximity to the phrenic nerve. And in this publication, I also describe the technique of sagittal splitting of the heart so that you can then visualize the pump head and able to divide and peel off the pump head with reasonable amount of safety, preventing damage to the phrenic nerve when you remove the pump head. And then sometimes you have more of those devices and it's not one. And when you eventually manage to take all of these devices and LVADs out of the chest, then you will, or you should be able to perform the heart transplant as a standard transplant with very little difficulty. Okay, I'm going to stop here. I just wanted to introduce to you two of our courses that is happening in Harefield Hospital. One is an online advanced heart failure course, which is going to be taking part in January 25. And also we have got the Harefield Cardiothoracic Transplant course, which is endorsed by the Royal College of Surgeons and the Society of Cardiothoracic Surgeons of Great Britain, again in London at Harefield Hospital, this time in May 2025. And with that, I thank you all.
Thank you, Espeed, for a wonderful presentation and overview. I mean, I think that doesn't, you kind of gave an overview, but it's not, doesn't give it real justice to exactly the pressure that surgeons are under at the time is limited and so on. But thank you so much for that. I think we've got quite a few questions already. Please keep them coming in. We've got sort of a few 22 minutes or so to have a bit of a discussion and then answer some of these questions. But I was hoping to start off, Espeed, we kind of alluded to LVAD therapy and transplantation and pulmonary vascular resistant pulmonary hypertension. But could you maybe kind of shed light as to what happens if you were to take a patient with pulmonary hypertension for transplantation, and what are the problems, and why is LVAD therapy actually the gold standard for such a patient rather than transplantation?
Thank you, Owais. Very, very good question. So if you have pulmonary vascular resistance, which is too high, then this will cause problems with your right ventricle of the donor heart. As you may know, that one of the most vulnerable parts of the donor heart is actually the right ventricle. And when the right ventricle arrives, quite often that is the one that causes issues and not able to withstand the pulmonary pressures. So if you have got high pulmonary pressure, then that will put the heart, which is already under pressure to perform after a long period of ischemia, against raised pulmonary pressure. And that is not good for the heart itself. So that predisposes the heart to failure straight away. However, using the left ventricular assist device would allow time to reduce the wedge pressure, reduce the afterload of the pulmonary circulation, and hence it will reduce the pulmonary vascular resistance over time. But that usually takes round about, it's variable, but I would say probably 1 to 2 years before the pulmonary pressures, depending on what we started at, would return into a reasonable amount, which, as we mentioned, is below 3 Wood's unit pulmonary vascular resistance, and a TPG of below 12 to 15. So I think that is one of the important things about putting a left ventricular assist device as a bridge to candidacy. And that is usually works really well.
Amazing. And I mean, I guess just sort of to add to that, in a way, I guess the point we're trying to make is, by the time, so let's say, for example, you have a patient with dilated cardiomyopathy and you've been following them up in your clinic and they're going on well, their pulmonary pressures, almost as a hidden menace, it's sort of going up and up and up and up and up. And by the time their BMP goes up and they get arrhythmias and they start to decompensate, NYHA class worsens, you then refer them. But we often see patients whose pulmonary pressures are already very high. The pulmonary vascular resistance is always very, very high. And instead of being eligible for a transplant, they then have to go down the LVAD route. And with the hope then the LVAD reverses the pulmonary pressures, which it does invariably, as Mr. Khoshbin said. And then they get transplant, but they always have to go through 2 big operations instead of having 1. So it's trying to identify these patients. So when you're seeing them in clinic, you're looking at the echo, you're looking quite seriously at the PA pressures and tracking that, as well as the BMP, and making that referral when you start to see the PA pressure climbing. So sort of another question.
If I may, is that if the PA pressure is significantly higher and the patient is unable to have a VAD or, to be able to go that direction, there's a possibility of heart-lung transplantation. But then there's an issue of having using 2 organs that could go to 2 people instead of 1. And also goes with the complexity of having a heart-lung transplantation.
Yeah, and I mean, of course, the long-term survival with a heart-lung transplant, we're talking about chalk and cheese here. I mean, it's significantly less than transplant on its own. So it is a possibility, but not an ideal one. So I've got a few questions on the chat, and please keep them coming through. I'll start off. They're very good questions, and one of them is, what's our experience with ECPella or Impeller 5.5 as a bridge to transplant? Espeed, I don't know if you would like to take that.
Yeah. So ECPella is a relatively new concept for us. It's not new, probably in some of the European countries. I know that they use it very regularly in Berlin. It's a good treatment, in my opinion. It doesn't need expertise. We do use Impeller on its own. For those of you who don't know what ECPella is ECPella is ECMO and impeller, and we use ECMO usually through an auxiliary approach, and at the same time the impeller goes through the same Y graft attached to the subclavian or axillary artery, and provides both ECMO and impeller. The ECMO will support the right heart very well, and the impeller will support and offload the left ventricle very well. And yes, it is a viable option, and this is something that we use. And we've used it in a similar way, not calling it ECPella in the way they describe it, through the same graft, but we have been using ECMO with offloading of the left ventricle with usually with a CP impeller rather than a 5.5, which is the most recent one. So it works and it's good. It's something that we're looking to maybe invest some time and experience on in the future.
Yeah, if I may just, Espeed, if I may just add to that, for the audience listening, there are many short-term mechanical extracorporeal devices that are available in the market. ECMO, CP impeller, 5.5 impeller, Centromag devices. They're almost like an LVAD, but outside the body, but that our surgeons implant. Now, they have a slightly different longevity. I would class mechanical support into durable mechanical support, where the patients go home with their device, and we've just described them in the presentations. And then you've got devices that are midterm. So the Centromag, it actually looks like an LVAD. The technology is the same, but all the piping and everything is outside the body. And these are kind of what I would describe as midterm devices. So patients can be mobilized on intensive care and can have a Centromag RVAD or Centromag LVAD or Centromag BiVAD and be waiting for months at a time for a heart transplant. And in answer to the question about 5.5 impeller and an ECPella, these devices are genuinely short term. You have weeks. I think you're pushing a month on these devices. So if you've got a patient who's blood group O and has got a really long time to wait for a suitable donor to become available, then having them on an ECPella or an impeller is probably not ideal, because they're going to accrue a complication that will make them untransplantable. And these short-term mechanical devices, there's risk of bleeding, infection, thrombosis, that can make them untransplantable. So you have to choose the right device. Now, the downside of these midterm devices like Levatronics, RVAD, LVAD, is that you need a sternotomy. So it's quite a brutal, big operation to go through. While the ECPellas are quite attractive because you don't have to do a sternotomy. It's percutaneously implanted. So you're saving the patient for their main operation, which would be the transplant. So that's kind of, I hope that answers the question. But our experience in using these devices is that depending on their waiting list and their likelihood of getting a transplant, we will use one device over the other. So if they've got a really projected long waiting time, we're more likely to use Levatronics devices rather than ECPella. So another question here for you. Yeah.
If I may add also,
go for it.
The impeller device is only licensed for 30 days. And as you said correctly, it's pushing it to 30 days. And also as long as, if you think that you have a patient who's going to be getting an organ within 13 days or much less than that, say someone, small guy with a blood group A on the super urgent list with no other patients with a blood group A, then it may be a good idea to do that. But we have perfected our art of doing Levatronics so that we can actually do that with minimal hassle and with very little concern.
Thanks, Espeed. So we've got quite a few questions here. We've got another sort of 10 or so questions, to be fair to everyone, and try and answer them as quickly as possible. It actually segues nicely into the next question: is what criteria do you use to prioritize patients for heart transplantation when resources are limited? And I guess that sort of follows on from what you've just said. I think, Espeed, you're saying super urgent, urgent, and routine listing, and maybe you could comment on that, and we can move to the next question.
Yeah, so if, when you consider patients for super urgent listing, you have to also have some idea of whether or not where they will stand in the national super urgent listing. So if these patients are, for example, if you've got 5 or 6 blood group O's who you have got a big patients who has got a blood group O, but he's at the bottom of the list, you know that it would be months and months before they will get an organ transplant. And you may decide that these patients may do better with maybe even with a durable device, provided that the right ventricle is functioning and they're managed. So you have to take into account patient blood group, patient size, progression of the disease, as I was mentioning before, and then decide on that. Patients on the urgent list then again varies about how they are, whether or not they're stable, and whether or not they need to be escalated. So they may escalate from urgent to super urgent list. So this is the way we deal with it nationally, and I think that's how we prioritize patients on urgent list and super urgent list, and the rest of the routine patients. And a lot of our patients who have got LVAD, durable LVAD, they are on the routine list.
Thanks, Espeed. So yeah, so the super urgent list patients are usually on short-term mechanical support. They wait days, weeks. Urgent list patients are largely inotrope dependent. They often wait months. And then the routine patients are not inotrope dependent, are at home, and they often wait years. And that's kind of trying to prioritize people based on urgency and waiting time. Then we've got another question here about, maybe I'm going to take this one, is how can one bridge the gap in practice between early recognition of advanced heart failure in a DGH, district general hospital, and effective escalation to quaternary centers for candidacy assessment? So I think what I would say is that to bridge this gap between district general hospitals and a transplant center, you've got to have sort of close ties and links with your transplant cardiologists and transplant surgeons. And we have really good relationship with many centers around us where, their colleagues and friends, they pick up the phone and we just discuss patients. We've got regular, since the advent of COVID and MS Teams and Zoom sort of chats, we're able to talk and discuss patients, look at their cases, look at the echo, and come to conclusions. So I'd really encourage you to reach out to your local transplant center and develop these relationships so you get the most for your patients. And a simple phone call is often what's needed, and you can kind of plan a trajectory. One of the other questions here is, what parameters do you see to predict RV failure after LVAD implantation? Espeed, would you like to take that one?
Yeah, so obviously echo findings are very important. If they have got evidence of severe RV impairment, well, this is always not a good start. If they have moderate LV impairment, but they are producing good PA pressures, that means that they're producing enough pressure with the LV and it's not failed, then this is also good. There are other parameters such as PAPI and other sort of scoring systems that will help in determining whether or not a patient will do well and will escape having a supplementary RVAD after LVAD support. However, in my experience, in most patients, if they are generating good PA pressures, probably PA pressure of systolic of round about 50 or above, and they have got on echo findings a good, well, at least moderate, less than moderate impairment in RV function, I think they most do really well. Yeah, and if they don't, then we have got strategies for temporary RV support, and about 10% of patients who go for LVAD therapy will end up with right ventricular, temporary right ventricular support, which we provide through percutaneous approach and a graft onto the PA, which is very easy to deal with and removed at the end. So I think this is a real problem. It needs further investigation. There are scoring systems at the moment available in the literature. However, they are not appropriately, adequately validated, so they're not in widespread use.
Thanks, Espeed. Yeah, I think I agree with that. I think there isn't really a scoring system out there that was highly predictive. But what you can say is you get these right ventricles that are grossly dilated. You've got a low RA pressure, a really, really high wedge pressure, and that's often a really bad sign. Dilated right ventricle, really high wedge pressure with a low right atrial pressure. There really isn't much left. If that RV is not generating any pressure, those ventricles kind of would worry me. But it's always possible to do it and try, but it is risky. And as I said in my talk, a third of patients will need some kind of RV support, whether it's just diuretic long-term or not, when followed with LVAD therapy. So it can become an issue afterwards. It just needs careful assessment, right heart catheterization, and so on. So we've got 4 more minutes left before this talk. There's quite a lot of questions. I'm trying to be fair to everybody. How do you manage patients who are ineligible for transplantation but still require advanced heart failure therapies? Espeed, so I get this links. There's a couple of questions on this line. So if somebody with a BMI of 38 and they're only 20 or 30 years old, they're quite young, how do we manage people like that?
Yeah, well, remember always we had a similar patient to that some time ago, very, very young patient who has had very high BMI, and he was doing really badly, and we had to actually opt to put a durable VAD. And that's one of the situations that I was mentioning about using the patients who are, say, in Intermax class 1 or 2, who you could go straight to put in a durable VAD in these patients and get them over their initial problem. And he did really well. As we all know, he's done extremely well, and he is soon going to be on transplant list, if not already on the transplant list. So yes, there are ways of doing this. There are some compassionate reactions that we have in particular in a very young patient, and we have got good experience with that. He's done extremely well, and he's lost a lot of weight because he's now able to go and exercise as a young man, doing fantastically well.
Thank you. So one final question. It's 429. What is the follow-up for patients following LVAD therapy and assessing patients following LVAD therapy? Is it solely done in an LVAD center, or can it be done at a DGH? And if you're a DGH cardiologist, what kind of parameters do you look at on echo? So I'll probably take that one, Espeed, if that's all right. So yeah, all our patients are for life. When they have their LVAD, they're followed up here. We've got an absolutely superb, excellent team of specialist nurses, LVAD specialist nurses who carry a bleep with them 24/7, and there's always somebody on call to provide advice if our patients get admitted to another center, and they'll provide advice, even go out to the hospital and provide training. But we follow them up. We routinely see our patients, the stable ones, every 3 months. And for others who have very little social support, will come on a weekly or fortnightly basis to get their driveline dressing changed and so on. But most of the patients, I don't want to give you the wrong impression, I'll do generally well, but they get sort of issues with minor infections, bleeding, INRs out of control that need sort of tweaking, and they are heart failure patients. We need to up-titrate their heart failure meds, the ACE inhibitors, the beta blockers, aldosterone antagonists. So all of that still matters. With regard to patients getting into their local hospital with their LVAD, I would just advise ringing the LVAD center. There should always be somebody on call that can provide you advice about what to look for and when. And the nitty-gritty of getting into diagnosing VAD thrombosis is quite nuanced. Involves looking at the aortic valve, looking at plasma hemoglobin levels in the blood, LDH levels, and the VAD itself has readings, flow rates, power, which also are indicative of whether there's potential thrombosis. All these things put together. But I would just highly recommend you ring the VAD center in a scenario where you see a VAD patient in your hospitals. So I think it's 4:31 now. I think I'm afraid we have to stop. There's quite a few questions. I'm really bad to call it. And I'd like to thank Espeed for a wonderful talk. I'd like to thank also Radcliffe Cardiology for organizing and setting up this event. And as Mr. Khoshbin said, there is a course in January 16th, 17th, and 18th, which is run on Microsoft Teams. And I'd encourage you to join that. It's over 3 days, and we deliver the International Society of Heart and Lung Transplant curriculum with specialists from all over the world to deliver immunology, rehab, all the evidence base in advanced heart failure surgery. So I'd recommend you join that. You're more than welcome. And there's also an observership program here as well if you want to come to Harefield for 3 weeks, and you can see Mr. Khoshbin operate and see us in the cath lab and on the wards and see what all the theory that we've provided here in real life. So once again, I'd like to thank you, the audience, for such amazing questions and for your attention. I hope you've enjoyed the session. And finally, thank you to Radcliffe Cardiology. So I wish you all a good evening and a good day. Thank you.
Thank you very much for joining.